Welcome back to our gynecology lectures. This will be a talk on uterine leiomyoma, or more commonly known to your patients and even possibly to a lot of medical professionals as fibroids, uterine fibroids. And that's a perfectly reasonable name to call it. The reason we don't call it fibroids technically is that it's not fibrous tissue that the fibroids are made out of. It's smooth muscle tissue. Now, we'll see over time it can become more fibrous tissue that makes up these quote-unquote fibroids, but the best name for the technically correct name for fibroids is uterine leiomyoma. And important that you distinguish it as uterine leiomyoma too, because leiomyoma can happen elsewhere, including the bladder, very close to the uterus. We'll start with a vignette. 38-year-old woman presents to your clinic complaining of heavier menstrual flow for the past year. This is accompanied by a sensation of fullness in the pelvis, but no significant pain, though lately she occasionally experiences some very mild pain during intercourse. She's a G1P1001, meaning she's been pregnant once, and she had a child at term. And she does not use oral contraceptives, as her husband had a vasectomy several years ago. She's monogamous, no history of STDs. Her first menses was at age 10, and she has a regular 28-day cycle. Her medical history is significant for hypothyroidism, for which she is managed with Synthroid. Her BMI is 31.2, and she's presently on a diet and exercise program. She says, "I'm trying to lose weight, but I've always been a bit bigger." There's no remarkable family history. Pelvic exam reveals an irregularly enlarged, non-tender uterus with palpable, firm nodularity. Okay, so listen to this. You already know what it is because our lecture is named Uterine Fibroids, Uterine Leiomyoma, and so that's what this is. Now, how do we know this? And how can we surmise this from our vignette? Now, first of all, uterine fibroids, uterine leiomyoma, they are extremely common. The literature has put it anywhere between 8% of all women, very conservatively, all the way up to 60 and even 80% of women subclinically as they get older, 40, 50 years of age. So it's a very, very, very large amount of women, probably somewhere in the 15 to 20% range of women that have fibroids, and the incidence goes up as women get older, as we're going to see. So she's 38. That's a very, very classic time for a woman to start, if she does have fibroids, which she may have earlier, to start, the fibroids get large enough to where they cause symptoms. And the most common symptom that fibroids cause is increased menstrual flow. You may not diagnose it as menorrhagia. Usually she should have some kind of objective sign of heavy menstrual flow to really diagnose it as menorrhagia. But the fact that her menstrual flow is heavier than it used to be is a sign that there might be something up. And then there's also this sensation of fullness in the pelvis. A lot of women will describe this. They feel like there's something up there, and there probably is. Women are pretty in tune with their organs, their female organs, as you're going to find, especially if you're a male practitioner like me. You'll find that women are very, very, very acquainted with themselves. Much more so than we are with ourselves, I think. There's some mild pain during intercourse. That may or may not be significant. But then we get to some more significant information. Her first menses was at age 10. What's unique about that? What's different? What's the average age for menarche in the United States? 12 years and about 4 or 5 months. So 12.4 years old is the average age for menses. She hit menses quite earlier, and we're going to see that's a risk factor for fibroids. Also, she's obese. Her BMI is 31.2. Another risk factor. You can see where this is going. Hyperestrogenic state. She makes more estrogen because she hit menarche earlier. She's been exposed to more estrogen in her life, I should say. Her BMI is higher. That's going to cause more estrogen because of the adiposity. Also, look at this patient I put here. She's black. Black women have a significantly higher rate of fibroids compared to other races. And then the pelvic exam reveals an irregularly enlarged, non-tender uterus with palpable firm nodularity. Irregular, non-tender, and firm. That's going to help us distinguish this from something else that is very, very, very important to distinguish this from, especially a certain variant of it. Do you know what I'm talking about? I'm talking about adenomyosis. Focal adenomyosis presents very similarly to fibroids. One of the differences, though, is on how it feels. And you're not always going to be able to distinguish this definitively on physical exam. But classically, adenomyosis is confluent. The diffuse adenomyosis, so you have a confluently enlarged uterus, and the uterus with adenomyosis is tender. So these are foci. Adenomyosis is foci of endometrial tissue inside the myometrium, and what that causes is increased prostaglandins. That's going to cause pain. That doesn't happen with fibroids. So with adenomyosis, you'll have a confluently enlarged, tender uterus, and it's going to be more boggy rather than firm. On the other hand, with fibroids, it's going to be more irregular, maybe bumpy kind of feeling, and it's going to be non-tender or maybe minimally tender, and it'll be firm, not boggy. So the sites of irregularity will be firm. All right, so we'll start out just sort of talking about the pathophysiology. I want you to, if you've watched the adenomyosis lecture, I want you to be mentally distinguishing this, because classically test questions will try to trip you up between focal adenomyosis and fibroids. And if you haven't watched that, you should watch that one next, I would recommend. We'll talk about the epidemiology and risk factors, how this presents, how you can work it up, some things you want to distinguish it from, and then management. This can present in a variety of different ways. So a uterine leiomyoma, or a fibroid, I call it fibroids because I'm so used to talking with patients, referring it to fibroids because that's what they know. If you call it a leiomyoma to a patient, they're going to hear oma and they're going to think, oh, carcinoma. So just say fibroids with a patient, don't scare them. It's a benign smooth muscle neoplasm originating from the myometrial cells. So that's a reason why we try to avoid calling this fibroids, because in the technical term, it's not fibrous tissue. It is muscular tissue, smooth muscular tissue. It's a neoplasm made out of smooth muscle. Now, as we're going to see, these can degenerate, and then the tissue gets replaced with connective tissue, fibrous tissue. And then in that case, it's more of a fibroid in the practical sense of the term. But this is a smooth muscle neoplasm. It extends out of the myometrium, and it can invade into the uterine cavity, as we're going to see, or it can even invade out the serosa of the uterus and into the peritoneum. Or even into the broad ligament. So it can be in a variety of different places, but it originates from the myometrium. Typically, it's clinically insignificant. A lot of women have these, but they just don't know it. But it's very, very common, and that's the reason why we need to be aware of this, because it's so common that even though it's clinically insignificant in the majority of cases, the fact that it's so common, that small minority of women that do have this and do have symptoms makes up a lot of women because it's very common. How does it appear? This isn't so important for the test purposes, but it's a good way to get a mental image in your head. So grossly, it tends to be elliptical, globular, circular in shape. They tend to be pearly, white, and firm. Usually when they are, a lot of cases when they're excised, they're degenerated, and so some of the tissue can be different, doesn't really appear as smooth muscle. But they tend to be this pearly white or firm, pearly white color. They're firm, as you can imagine, based on what we described from physical exam. They kind of have like a rubbery looking consistency, and they're covered by a distinct connective tissue. And this is actually clinically significant because when a surgeon goes in to remove the leiomyoma, if they do a myomectomy, it's actually very easy to shell this out of the uterus because of that connective tissue that surrounds it. It's very easy to pull it right out of the uterus without tearing out surrounding tissue for the most part. Histologically, it's got elongated smooth muscle cells, which are aggregated together in bundles. And then there's minimal to no mitotic activity. And that's going to help the pathologist distinguish this from a leiomyosarcoma, which is really a malignant variant of the leiomyoma. And then there's a lack of vascular organization, but there still is some vascularity to it. It does get nutrition from vasculature. This is living tissue, but it can outgrow that vasculature, and we'll talk about what happens with that in a little bit. The average growth rate is approximately 0.5 centimeters per year, but that can vary based on how much estrogen a woman is subjected to. So if, for instance, a woman let's say she's got PCOS, where she's going to be exposed to much more estrogen, and the reason for that is the anovulation, the unopposed estrogen that comes with PCOS. Her fibroids are going to grow a lot faster. She's exposed to a lot more estrogen. So the growth rate can vary. And you can probably surmise from what I just said that leiomyomas are estrogen sensitive and progesterone sensitive. And so that is similar to the adenomyosis and endometriosis. These are all estrogen and progesterone sensitive, and so the treatment is going to be very similar, as you can probably imagine from that, that if it's estrogen and progesterone sensitive, what do we want to do? We want to cut it off from estrogen and progesterone. All right, leiomyomas themselves create a hyperestrogenic environment, and so basically they are feeding themselves. So it doesn't just depend on the estrogen that comes with the woman's natural cycles. These leiomyomas, fibroids, can actually feed themselves, and they can create a contained hyperestrogenic environment. Why do they do that? How do they do that? Leiomyoma cells, compared to normal myometrial cells, contain more estrogen receptors. So they're more sensitive to estrogen than your typical myometrial cells. Also, leiomyoma cells they convert less estradiol to estrone. There's an enzyme, it's got a real long name, don't worry about it. I don't even remember the name of it. But there's an enzyme that converts estradiol, which is an estrogen, to estrone, which is a more inactive estrogen. Estrone, remember, is the estrogen that predominates in postmenopausal women. Estradiol will naturally get converted into estrone by the body. It's a way of just sort of deactivating the estradiol, which is a much more biologically active estrogen than estrone is. But if the cell converts estradiol to estrone relatively less, then you're going to have more active estradiol compared to the inactive estrone, and so you're going to have more estrogenic activity. And then leiomyoma cells contain more aromatase enzyme, and that is the enzyme that converts other sex hormones, cholesterol, to estrogens. So cytologically, estrogen and progesterone stimulate production of various cellular growth factors at a transcriptional level, as the steroid hormones do, and that's going to result in cellular activity and cell growth. And so that's how these leiomyomas enlarge themselves and proliferate. Progestins also have an effect on leiomyomas, but what that effect is really unclear. So if progestins are given alone, so for instance, medroxyprogesterone acetate, they decrease the growth of the fibroid. However, if they're given with GnRH agonists like Lupron, then they actually accelerate growth. Now that doesn't really make any sense because progestins themselves decrease growth and GnRH agonists decrease growth. Lupron is something that's, I wouldn't say very commonly given, but it is something that is prescribed with some frequency for more refractory leiomyomas. So each of these, progestins and GnRH agonists, they both slow growth of fibroids. But if you give the two together, they accelerate the growth together. So we don't really know why that is. We're not exactly sure the mechanism behind how progestins themselves act on leiomyomas. So it's not fully elucidated. What are the risk factors? As we mentioned, age. So the incidence of leiomyoma increases with age during the reproductive years. And that's important, during the reproductive years. Once a woman hits menopause, what stops happening? She's not exposed to estrogen as much, and those fibroids will tend to die down. They sort of shrivel up. They won't go away, but they shrink. And so a woman after menopause is less likely to present with symptoms related to fibroids than a woman during her reproductive years. But with time, the more estrogen you're exposed to, over time, those fibroids will get bigger and bigger and bigger, and that's why we see women tend to present with these a little bit later on in life. You're not going to see a 19-year-old presenting with fibroids. Typically, these women are in their 30s and 40s. Race, more frequent in blacks than other races. No idea why. Now, the first thing that might come to mind is, well, in the United States, blacks tend to have a higher obesity rate than whites. That's a fact. But Nigerian women have a higher rate of leiomyoma than European women, and Nigerian women are not any more overweight than anybody else. So it is a genetic factor going on here. So more frequent in blacks than other races. Family history, the risk increases twofold if you have a affected primary relative, so a daughter, sister, mother. BMI, if you're overweight or obese, it increases your risk. Clearly, adiposity, we know that the fatter you are, the more estrogen you're making. Early menarche, it all has to do with the lifetime exposure to estrogen. So the earlier you hit menarche, the more likely you are to develop leiomyoma. And then medical conditions such as PCOS, which is going to create a hyperestrogenic state. The risk decreases with parity, and that probably has something to do with the configurational changes of the uterus that occur with pregnancy. Also giving birth at an early age, and then the use of combined oral contraceptives will decrease the risk of leiomyoma. Oh, another thing is smoking has been shown to be inversely correlated with leiomyoma. Not sure why, but it is. So these are some ways that you can find fibroids. The most common one is going to be this one here, the intramural fibroid. So the intramural fibroid is entirely contained within the myometrium. There are some other ways, though, that it can show up. So submucosal. Submucosal is sitting just below the endometrial layer and then partially into the myometrium. And then there's subserosal, and subserosal is more on the outside of the uterus, so along the serosal layer of tissue. And then there's intracavitary. That's really just along the spectrum of sort of intramural, submucosal, intracavitary. Intracavitary leiomyomas are connected to the myometrium via this little stalk. We call it pedunculated. And so it's connected to the myometrium with this stalk, and this is myometrial tissue here that sits within the uterine cavity. And this can be very difficult to distinguish from an endometrial polyp, as we're going to see. And then you can also get these sort of pedunculated-like tumors, fibroids on the uterine corpus. And these can actually become detached, and they can actually connect to other pelvic structures and use its vasculature. And we call those parasitic leiomyomas. So we may have alluded to the fact that fibroids can reduce fertility. Which of these do you think is going to be the most problematic for fertility? So the submucosal and intracavitary fibroids are going to be the most problematic for fertility because they can block the tubal ostia. And they distort the anatomy, and you can get implantation, abnormal implantation, so that can be problematic. So this is how fibroids look grossly. Now, when I first saw this picture, I thought, is this a bicornuate uterus? No. The pathologist just sliced this uterus right down the middle. So this is the cervix down here, and here's the uterus up here. So you can see 1, 2, 3. There's only 3, not 6. Okay, these are all just cut in half. You can see it's symmetrical. So there's 3 fibroids here. And these are all intramural fibroids. Although this one, it's hard to tell. This one might be subserosal. Possibly this one, but this one's definitely intramural. Ultimately, it doesn't really matter. Okay, so how does this present? Most women with uterine leiomyoma are going to be asymptomatic, as we mentioned. The most common presenting features are menorrhagia, often accompanied with some level of pelvic pressure. When these get big enough, these can be like a 12-week, even 14, 16-week size of the uterus. So a woman will start to be able to feel it. If they get big enough, actually, they can cause urinary problems because they can impinge upon either the ureter or the bladder, so they can cause frequency and incontinence, and they can even obstruct the ureter, and that can lead to serious problems, as you can imagine. The other things that this can cause, generally it's not going to be associated so much with pain. You'll see dysmenorrhea is commonly described, but there's been studies that have shown that dyspareunia or non-cyclical pelvic pain is more associated with fibroids than dysmenorrhea. But pain is really not so prominent a feature here as it is in adenomyosis. The abnormal bleeding is typically going to present as menorrhagia, so heavier menstrual flow. However, it can be associated with some mild intercyclical spotting. Intercyclical, so between cycles. Intercyclical spotting. Okay, mid-cycle spotting. Dysmenorrhea, dyspareunia, non-cyclical pelvic pain, we talked about that. Not so big of a feature with leiomyomas, but it can happen, especially as they get bigger. Infertility. So while leiomyomas don't commonly cause infertility, a common cause of infertility is leiomyoma. So let me put it in a better way. If you take all the women that have fibroids, relatively few of them are going to have problems with fertility. But if you take all the women that are infertile, a decent amount of them are going to have fibroids, and possibly even fibroids being the cause. So an estimated 2 to 3% of cases of infertility are actually due to fibroids. And that's a lot when you think of all the possible causes of infertility that there can be. So 2 to 3% of cases of infertility. So definitely something to keep on your differential of infertility, and this is why we do hysteroscopy or a hysterosalpingogram when we work women up for infertility. Acute pelvic pain. So chronic pain is possible, some mild chronic pain, but you can also get severe acute pain. And there are various ways that can happen. The most common reason is due to a degeneration of the leiomyoma. And there's various ways that a fibroid can degenerate, but the one that's really going to cause the pain is what we call red degeneration of fibroid, red degeneration. Also called carneous degeneration. There's other types of degeneration, but they're really clinically insignificant. The other way that this can cause pain is rarely you can get torsion of a subserosal pedunculated leiomyoma. So going back here, these can twist, and ultimately then they can cause pain that way because the tissue dies off and necroses and releases inflammatory mediators. I don't think I mentioned, another way that these leiomyomas can show up is what we call intraligamentary. So they can be in the broad ligament, outside of the uterus itself. That's another way, rarely, that these can show up. Okay, so the types of degeneration, most fibroids will undergo degeneration at some point. 2/3 of them will undergo degeneration. Hyaline degeneration is the most common, but it's clinically insignificant because it doesn't cause any symptoms. And you really wouldn't know that there is hyaline degeneration unless you did a biopsy of it. So it's the most common type of degeneration. About 60% of all fibroids will undergo hyaline degeneration. what happens here is that the fibroids just outgrow their blood supply, and that results in a replacement of the smooth muscle tissue gets replaced with hyaline tissue or connective tissue. And this can progress to a couple other different types of degeneration. So there's the cystic degeneration. I don't think I put that on here. Anyway, cystic degeneration usually occurs after menopause. Basically what happens is that some of that fibroid tissue, that connective tissue, will necrose, and consequential to that you get these little bubbles. So they kind of look like bubbles if you were to cut the fibroid open. So they're little cysts. And a lot of times you'll be able to see that on sonography. But if this happens in a woman before menopause and you look at this on sonography, just by the way it looks, it can be misdiagnosed as some kind of obstetrical thing going on. So it can look like a hydatidiform mole. It can look like a missed abortion. So that's something to keep in mind as a possibility if you see this sort of cystic-like structure in a woman of childbearing age. And so the important one that I wanted to talk about here is the red carneous degeneration. And this is common during or shortly after pregnancy. Why? Because as the uterus gets bigger, what can happen is you can get venous obstruction. The vein that drains the circulation that goes to the fibroid. And what happens then is that you get a hemorrhagic infarction, and then there's necrosis, and the fibroid is going to release inflammatory mediators. And so rather than this slow necrosis that you get with the hyaline degeneration, you get a more rapid necrosis, and it's going to release inflammatory mediators, and it's going to look a lot like an infection. So you can get acute pain, you get fever, you get increased white count, but it's all due to those inflammatory mediators. This is totally aseptic. No bacterial process going on, but it looks very disturbingly like any of the infectious processes that can go on in the reproductive tract. And usually what winds up happening is that it's so difficult to differentiate this from endometritis or other infectious processes that rather than just waiting on it, waiting to figure it out, a lot of these women will just be admitted to the hospital, given NSAIDs for the pain, fluids, and broad-spectrum antibiotics to just empirically treat them. And so what would you want to give them? You're going to be treating them for endometritis, presumptive endometritis, even though it may be red degeneration, which is behind it. If you're treating endometritis, you want to give broad-spectrum antibiotics, so typically clindamycin and gentamicin together, IV every 8 hours for 2 or 3 days. Or if the woman is pregnant, and because a lot of these red degenerations will present in pregnant women, and if you don't know if it's infection or if it's red degeneration, you can give her broad-spectrum antibiotics, but you should probably not give gentamicin because that's pregnancy class D, and as you know, it can cause a lot of issues in babies. It's a aminoglycoside, so you want to avoid that. So you can give something like Unicin, ampicillin sulbactam, if I am remembering correctly. That's pregnancy class B, I believe, and so that's perfectly reasonable to give to a woman if you think endometritis. So just put that out there. It's probably not something you're going to run into on a test, but it can be very difficult to distinguish the red degeneration from an actual infection. But if you don't give the antibiotics, the pain and the fever will go away because this is not a bacterial process if this is truly red degeneration. All right, so I think I belabored that enough. How do we work this up? So you're going to detect this on physical exam. Sometimes it may even just be an incidental finding because a woman does not have any symptoms from it. You're just doing an annual pelvic exam and you note this irregular contour. It should be non-tender or minimally tender. If it's very tender, you should think of possibly focal adenomyosis, possibly depending on where it is or if there's any other nodularity. You could possibly even think of endometriosis. Typically women will present with symptoms with that though, in a lot of cases. Any woman of reproductive age who has uterine enlargement should get a beta-HCG test to rule out pregnancy. That's a very, very, very common rule in OBGYN. Is get a beta HCG test in a woman of reproductive age with any possible OB-GYN problem going on. Because there's so many different drugs you can do, tests you can do, interventions that you can undertake that can be dangerous to a pregnancy if it's there. Beta HCG tests are super cheap. So get a qualitative beta HCG, rule out pregnancy because you have an enlarged uterus. Although, since you're going on to sonography, you may not even need to do that because you may be able to see any possible pregnancy that's there. The imaging modality of choice is going to be sonography, transvaginal sonography. Now, if you think back to how these fibroids, where they can be, you can imagine that in a closed uterus, there's not much space within the uterus, and it's just potential space. Some of these fibroids can be difficult to distinguish. So particularly those intracavitary fibroids, you wouldn't be able to see those very well with TVS or really any sonography. So in those cases, a lot of gynecologists will just go straight to this. They'll just do a saline infusion, and that sort of blows up not blow up, but it expands the uterus, separates the walls to help delineate the uterine anatomy a little bit more readily. So leiomyomas on sonography, they can be hyperechoic or they can be hypoechoic. It really just depends on the tissue, whether there's been degeneration that's gone on. And so this can be difficult to distinguish from adenomyosis. It can be difficult to distinguish from endometrial polyps if this is an intracavitary fibroid. And so the Doppler is very useful to the sonographer. Now, I don't expect you to get asked anything like this on a test, but it's a good thing to know if you want to impress your gynecology attendings. Okay, so you should be aware to some degree of how this looks on an ultrasound. So this is a hypoechoic mass that exists within the myometrium. So here's our endometrium here, this more whitish, more hyperechoic tissue. We call this the endometrial stripe. And then this more hypoechoic tissue here, this layer is the myometrium. And you can see this distinct mass here within the myometrium. It's the serosa. So this is an intramural leiomyoma. And this is a more hypoechoic mass. And if you look really closely, you can see these sort of circular regions with more hyperechoic tissue here and hypoechoic tissue here. This could be possibly a cystic degeneration going on, but I'm not sure exactly. So here you see more of a hyperechoic mass. Now you can get calcific degeneration, which typically happens after you have necrosis and the tissue calcifies. In that case, the leiomyoma will be more hyperechoic. So here you see it right here. And this again is intramural. And so you see another one here. Again, here this is the uterus here. You can kind of see the endometrium here. And it's hard to distinguish what kind of fibroid this is because it's so large that it's hard to tell if this is the myometrium up here and this is intracavitary, or if this is the endometrium down here getting pressed up against the endometrial tissue across from it, and really this is intramural. That's probably what this is. This is probably intramural because it's the most common location. But what would really help, obviously, would be to get a saline infusion here. We don't have one here, and so it can be difficult. And you might be wondering, why is it so important to be able to tell all these apart? Not so much for your test-taking purposes, but if a woman were to go in and get surgery to have something like this removed, it's obviously going to be very important to the gynecologist because it's going to dictate what kind of surgical approach they use. Okay, this is a subserosal fibroid. So here's the uterus out here, here's the urinary bladder, and the fibroid is actually sitting on the external surface of the uterus. And then this is an intracavitary fibroid. So this is the corpus of the uterus here, and this is the cavity, and this is the fibroid. What does this look like? This looks a lot like this. But this is not a fibroid, this is actually a polyp. So how do you tell the two of these apart? You really can't. You might say, oh, this is more hyperechoic, and you'd be right, but that's not how you tell them apart. What you can use is Doppler. Doppler is your friend. And so this is a leiomyoma in Doppler. And what we see with leiomyomas is that there's a tendency for them to have this. So if you should know that a Doppler is just looking at flow, looking at blood flow. And the blood that's moving towards you is red, away from you is blue, so you can kind of, you have arteries and veins. But this is blood flow here. So here's our mass right here, and this along here is the blood flow. And the way that leiomyomas tend to show up on Doppler is you have like a rim of blood flow, but not so much in the middle, within the fibroid. You have more of the blood flow sits around the rim. Okay, and sometimes you can have some penetrating vessels, but for the most part, you're going to see most of it along the rim, along the periphery of the mass. Okay, so here you see it again. So fibroid, there's a uterus down here, and you see it along the rim. Now this is adenomyosis. So here's a mass with adenomyosis, and a few different masses here. But with adenomyosis, it's more confluent. You don't see that rimming effect. And then this is an endometrial polyp. What do you note here? So here's your mass, obviously. And with endometrial polyps, there'll tend to be a single, maybe one or two vessels that go up the stalk of the mass. And this is the endometrial polyp. Okay, so you're looking, not sure what section this is, but essentially this is the stalk here, and then this is the body. And it's coming off the tissue here, off the endometrial tissue. So this is an endometrial polyp. So you see these one or two prominent vessels. Okay, so what is this? So here's our mass. Here's the uterus, mass here. It's focal adenomyosis. How about this one? And this is probably a little tricky here because this actually isn't in the uterus, this is in the cervix, but if you can still get fibroids there, this is a fibroid, it's going to give you the same appearance. So you see this rimming here, this is your mass, there's rimming here, and not so much vasculature in the middle, it's along the rims. What about this one? This one is more obviously, this mass here is a fibroid. How about this one? So here's our mass, and you note this vessel right here. It's an endometrial polyp. And what about this one? Okay, here's the uterus, here's the mass, and here's our single artery. And we think it's an artery here. It's red. That doesn't necessarily tell you if it's an artery or vein. If you're using Doppler, you need to distinguish yourself whether you're hovering over an artery or vein. So like if you're doing Doppler like on femoral artery or something, you need to know, okay, here's my artery. All right, now I see that this vessel is red, so I know this is an artery, so everything that's red is artery and everything that's blue is vein. So whether it's red or blue just depends on the computer. It doesn't tell you, just because it's red doesn't mean it's an artery. Hopefully that makes sense. Okay, so that's a polyp. And what's this? Here's our mass here. This one's a little bit trickier, but you can see the mass and then rimming. So this is a fibroid. So how do we manage this? Most fibroids are minimally symptomatic, so most of them, woman's not really going to want any kind of treatment. You can give her NSAIDs for pain as needed, but for the most part, it's not going to really require any prescriptions on your part. NSAIDs are our go-to for pain. However, if it's causing menorrhagia, and that's a problem for her, either if it's causing anemia or if it's just inconvenient for her, combined oral contraceptives are our first go-to. They're cheaper. However, another thing that you can give, and there are some drawbacks to it, and you can't give it everybody, but you can give levonorgestrel, and that's in the intrauterine system. So we call that Mirena, as the trade name. But this is a system that's inserted up the cervix into the uterus, and it kind of, the way it's inserted is kind of weird, but it kind of like grabs onto the bottom of the uterus, and you can leave it there for up to 5 years. But this will release levonorgestrel over time, and that will help both with the pain and the menorrhagia. Now, what happens in women with fibroids that might preclude this? The anatomy can get distorted. And so if the anatomy is sufficiently distorted, they can lose their Mirena. It can become disenlarged, for lack of a better word. So you can't give that in everybody. If they've got distortion, then you can't give that. But for the most part, in most women, you can use this, and this is good. GnRH agonists like Lupron are very useful. So this is more for refractory fibroids that don't respond to oral contraceptives, or if you can't give Mirena. So Lupron, Zoladex, Cinerel. Cinerel is nasal, so that can be good for some women that want to take it that way. But there's a problem with this. With the GnRH agonists, you're really reducing the amount of estrogen the woman has, and that can decrease bone mineral density and have all sorts of problematic effects. So ACOG recommends that you don't use this more than 6 months without add-back therapy. And what add-back therapy is, if you go back to the endometriosis lecture, add-back therapy is where you just give enough estrogen and progesterone to prevent the adverse effects of the GnRH agonist, but not enough to counteract the GnRH agonists, in this case, to cause the fibroids to grow back again. So that's add-back treatment. Surgically, and then the GnRH agonists, they do have a host of side effects, but vasomotor changes, hot flashes, decreased libido, vaginal dryness, which can cause dyspareunia, which a lot of these women already struggle with anyway. Surgically, there's various ways you can go. Uterine artery embolization is a newer way. This uses interventional radiology. Essentially what you're doing here is you are placing a catheter in the femoral artery, advancing it with fluoroscopic guidance. You go up the femoral artery, so you're going backwards, to the common iliac bifurcation, and then through the internal iliac artery, and then down to the uterine artery. And that's the first branch of the anterior division of the internal iliac. And what you then do is you can inject this polyvinyl alcohol microspheres, and that is going to embolize the uterine artery, and that will cut off flow to the fibroids. Important though, if you do this, you have to do both uterine arteries, not just the one that's on the side of the fibroid, because there's so much collateral circulation. Before you do this, you have to make sure, obviously, patient's not pregnant. You got to get a PAP. You got to rule out any kind of STDs. You want to make sure that the patient doesn't have bleeding problems. So there's a lot of things that you have to do to make sure that the woman is a candidate. There's also some complications. Obviously, you're cutting off circulation to an organ, so you can have some pain from that. Usually it doesn't last more than a couple days, but you can get what's called post-embolization syndrome. That can last several days, and these women often have to be admitted because the pain is so severe, and they usually have to be given morphine. And then there's a 25% fail rate, and obviously if these women want to become pregnant later on, they can with a uterine artery embolization, but it definitely increases the amount of complications they can have. They're at increased risk of miscarriage. They can have preterm delivery. It increases the risk of fetal malpresentation, fetal growth retardation, and malplacentation, as you can imagine, since you're sort of disrupting the uterine tissue. So you can get like placenta previa, placenta accreta, placenta increta, etc. All right, what else? Myomectomy. So this is ideal for women who have they've got fibroids, and that's what's causing their infertility. So if a woman is infertile and she's having fertility issues, and we know it's due to fibroids, the myomectomy is the way to go. Obviously, you can't do the hysterectomy. Uterine artery embolization, we know, has a lot of problems as far as pregnancy goes. So myomectomy is the best surgical management if we're looking to improve her fertility. That can be done many ways: laparoscopically, hysteroscopically, or open. Remember, if you do it laparoscopically, you're cutting the uterus open. And so if you do that, remember that when these women go on to deliver their babies, what are you going to be doing? You're going to be doing a C-section, because you do not want to deliver a woman who's had her uterus cut open. There is VBAC, vaginal birth after C-section, but that's not going to fall into that because this isn't a C-section. So these women need to have C-sections after they get myomectomies, because remember the risk of uterine rupture. All right, so anyhow, that is it for fibroids. If you have any questions, go ahead and write me a note below. Otherwise, I will talk to you next time.